Good evening, fellow doctors and colleagues. For today's Dr. Sheng-Po retirement virtual webinar, we're honored to introduce Professor Nicolas Fakhry as our invited speaker. Nicolas Fakhry is a professor in the Department of Otolaryngology, Head and Neck Surgery at Love Conception Hospital and Aix-Marseille University in Marseille, France. He graduated from University of Medicine of Rennes and completed his residency training in Marseille. He then completed fellowship training at the University of Marseille's Department of Head and Neck Surgery. He completed a PhD in biologic anthropology in Aix-Marseille University in 2013. Nicolas Fakhry was associate professor from 2011 to 2015 and became professor of otolaryngology, head and neck surgery in 2015. Professor Fakhry is an active member of French ENT Society, the French Society of ENT Teachers, and the French Society of Head and Neck Cancer, from whom he received the award of his thesis of medicine in 2008. He is also a member of the European Head and Neck Society and the European Laryngological Society. Nicolas Fakhry is a founding member of the IFOS during the IFOS Congress of Paris in 2017 and has become honored to serve as the president of IFOS from 2017 to 2023. He has been elected as a member of the IFOS Executive Committee in 2023. Today, Professor Nicolas Fakhry presenting topic is results of the IFOS World Survey on access to head and neck cancer care. Please give a round of applause to welcome Professor Nicolas Fakhry.
Dear all, first of all, I would like to thank you for inviting me to learn the nature during the Sheng-Po ceremony to their series. I am Nicolas Fakhry. I come from Marseille, a very nice city located in the south of France, close to the Mediterranean Sea. And you can see on these pictures, very nice, all the harbor of Marseille. And this is here my hospital, named La Conception University Hospital, not very far from the old house. So my links to Sheng-Po are essentially the IFOS. We all know that Sheng-Po has served for the IFOS for many and many years, and in the name of many members of the IFOS, I would like to thank him for everything he has done for the IFOS. Personally, we met up during the Ho Chi Minh IFOS course organized in Vietnam in collaboration with IFOS, the French ENT Society, and the Young IFOS. And at this time, I was the president of the Young IFOS, and we have worked together with Sheng-Po to organize this international course. And I would like again thank Sheng-Po for his help during the organization. You can see here a picture with all the organizing committee of the Congress. You can see here a picture with the head and neck surgeon who have participated to the conference. And in the middle, we have Professor Tuse, who was the local chairperson of the Congress. It was very important in the organization. There is another picture with Professor Tuse, Sheng-Po, and me after a lecture during the course. We also work together with Sheng-Po and the IFOS and the Young IFOS on a survey about management of oral feeding following total laryngectomy around the world. It was a very interesting survey published in head and neck. We also participated together during the COVID-19 pandemic to a webinar of head and neck surgery in 2022 with many colleagues from all around the world. And finally, we all know the investment of Sheng-Po during the IFOS Dubai ENT World Congress, but also during the IFOS Congress that we will held in Istanbul in 2026, and I know that we will work together on it. So I look forward to working with him for this Congress. Now I'm going to talk about the present lecture, the IFOS World Survey on Access to Head and Neck Cancer Care. I have no conflicts of interest. We discussed during the Dubai Congress about a survey we could do around the world, and it seemed to be important to explore the factors influencing access to care in head and neck oncology around the world and to study differences between all continents. So we decided to develop an online survey to have general information about our head and neck surgeons around the world, about their diagnostic modalities available, about treatment decision, about treatments modalities, for example, robotic surgery, free flaps, about immunotherapy access, about nutritional patient management, and about global management of their patient. We then developed specific questions about cancer management, as we can see previously, and then we proposed clinical scenarios, that was the clinical cases, and send it to our colleagues. This survey was accepted for the Institutional Review Board of Aix-Marseille University. And then we developed the survey and then sent it to a group of experts. So the study was first developed in France with Victorine Mazot and me, and then we worked on this survey with Emmanuel Babin, Jean Mechien, and Carol Chiesa. And then the survey was reviewed by Isabelle Gengler in USA, and then we have sent it to the group of experts with Luis Kowalski from Brazil, to Hani Marzouki from Saudi Arabia, to Johannes Fagen from South Africa, to Bernard Lyons from Australia, to Mohamed Mod Razif from Malaysia, and of course to Sheng-Po in Taiwan. So we have a very expert group for the reviewing of this survey. And then we have translated in French and Spanish in order to send it all over the world. So the survey spread was done between February to March 2024 using SurveyMonkey, and we have sent it to the IFOS and UIFOS mailing list, and also to African Head and Neck Society members, Asian Society of Head and Neck Oncology members, Asia-Oceania Association of Otolaryngology Head and Neck Surgery Societies, the Pan-American Association of Otolaryngology, and the International French-Speaking ENT Society. We had finally 566 responses from more than 100 countries and 457 centers. And what we have very proud of is this map. You can see in colors all the countries where we had respondents, and you can see that it covers all the world. We had 27 responses from North America, 50 responses from Central and South America, 185 from Europe, 125 from Asia, 12 from Australia, 73 from Africa, and 114 for North Africa and Middle East. So for statistical analysis, we have decided to group North Africa, I mean the Maghreb, with the Middle East. First information about the practice of our colleagues. We would like to know if they work in private practice, community hospital, university-affiliated hospital, cancer center, humanitarian mission hospital, or military hospital. And the differences we have in our statistics is that we have more private practices in Central and South America and Oceania than the other parts of the world where there were more university-affiliated hospitals in terms of respondents. Concerning the number of patients taken care during every year, we have differences between a high volume center, I mean more than 100 patients every year, between Africa, Oceania, and Middle East, and the rest of the world. We had more high volume centers in Europe, North America, Central and South America, and Asia than in Africa, Oceania, and the Middle East and North Africa. Concerning diagnostic modalities, compared all continents, and our results show that except for Africa, 100% of head and neck surgeons have access to flexible nasofibroscopy. And in Africa, almost 20% of them have no access to flexible nasofibroscopy. In the world, 82% of head and neck surgeons have access to fine needle aspiration cytology without any significant difference between all continents. 96% have access to CT scans without any difference between continents. More than 90% have access to MRI, but we have differences because in Africa, only 52% have access to MRI. In Central and South America, 76%, and in Middle East and North Africa, 80%. It's the same with PET scan. Globally in the world, 74% have access to PET scan. Like in Africa, we can see that only 5.8% have access to PET CT, 46% in Central America and South America, and 41.6% in Middle East and North Africa. Finally, concerning endoscopy under general anesthesia, globally in the world, 83.6% have access to this modality, with statistically differences, with a lower access in Asia, only 65%, in Central and South America, 66%, and in Middle East and North Africa, 71%. A word about telemedicine that is very important and has developed a lot since COVID-19 pandemic. Globally, around the world, telemedicine is available for 34.5% of head and neck surgeons. And an example of the difference is that it's available for 84.6% of head and neck surgeons in North America and only 12.8% in Africa. Concerning treatment decision, first, a word about the multidisciplinary tumor board. We can see a very important difference between Europe and Oceania, where for 91% of respondents, all cases of cancer are discussed during MDT. And for only 28.6% in Central and South America and 25.4% in Africa, all cases of head and neck cancers are discussed during the multidisciplinary tumor board. Concerning the guidelines, you can see the results of the responses from all continents. Concerning local guidelines, the using is around 30% in Europe, North America, Africa, Oceania, and lower in Central and South America, Asia, and Middle East and North Africa. Concerning the using of national guidelines, we have a using of more than 60% in Europe, North America, Asia, Oceania, and lower using in Central America, South America, by 25%, Africa, and Middle East and North Africa. And finally, concerning international guidelines, we have an important using in Europe, South and Central America, Asia, Africa, Oceania, and Middle East and North Africa. In these continents, we have more than 70% of using. And surprisingly, we have a lower using in North America with only 46%. But the explanation is probably that the NCCN, that is considered as an international guidelines for many continents, is probably considered as national guidelines for American respondents. Concerning immunohistochemistry, first, the HPV testing or P16 overexpression, we have very important differences between continents with a using of, for example, almost 100% in Europe and only 40% in Africa and 57% in Middle East and North Africa. And the global using in the world is more than 90%. Concerning PD-L1 expression with CPS score quantification, we have a using in 84% of respondents in Europe and only 4.2% in Africa. Concerning treatments modalities. Concerning treatment modalities, we have here a very detailed table, and it's not possible to present all the results during this lecture. But if we look at the endoscopic surgery with laser, the access to this modality, for example, we have a very good access in Europe and North America of more than 70%, more limited access in Asia, South and Central America, and Oceania, and Middle East and North Africa, and very low access in Africa with less than 20%. Concerning transoral robotic surgery, we have an access of 65% in North America, an access of 47% in Europe, 36% in Asia, 20% in South and Central America, 27% in Oceania, and 10% in Middle East and North Africa, and 0% in Africa. Concerning sentinel node biopsy, we have a very good access in North America with 92%, a good access in Europe with around 60%, and the same in Oceania, and a lower access in the Middle East, and in Asia only 16%. Concerning free flap reconstruction, we have good access in all parts of the world, except for Middle East and North Africa, with an access lower than 50% and only 31% in Africa. What is very important to see is that in Africa, the access is very limited compared to the other part of the world. Concerning access to frozen section, we have a global access of almost 90% for all respondents in the world, and Africa has a very lower access to the states with less than 15%. Concerning the time before take a patient to operative room, the results are relatively homogeneous in the world. It's an excess of 88% in the months to go to the operative room for patient. Concerning radiotherapy, we have a good access to intensity modulated radiation therapy in Europe, North America, Central and South America, and lower access in the Middle East and North Africa, and very limited access in Oceania and Africa. Concerning chemotherapy, we have a broad access in all parts of the world with around 90%. It's different for immunotherapy with a global access of 67% in the world, but we have a very good access in Europe, North America, Central and South America, Asia and Oceania. The more limited access in the Middle East with 58% on a very low access in Africa with 4%. Concerning the difficulties to access to healthcare, the high cost is not a problem in Europe, but in all other parts of the world, it's a problem, even in North America, where the high cost is a difficulty for more than 40% of respondents. Concerning with religious and cultural beliefs and traditional medicine and myth and stereotypes about cancer, it's mainly in Africa where it's a limitation and a difficulty to access to healthcare. Concerning the difficulty of access to healthcare structure, surprisingly, it's a problem in all parts of the world, even in North America with 50%, and it's lower in Asia with only 16%. And finally, concerning the lack of reference centers, it's not a problem in Europe, North America, Asia, Oceania, and Middle East and North Africa, and it's a problem in 40% of cases of respondents in Central and South America and in Africa. So all these results show that there is an equal access to care within and between continents. You can see that Africa generally had less access to diagnostic and therapeutic modalities compared to other continents. And the limitation to access to care that we have found out that are known many low-income countries is the high cost, difficulties of access to healthcare structures, the lack of reference centers, and religious and cultural beliefs, many in Africa. But globally, we have seen a very important heterogeneity of practices, and I can illustrate it with clinical cases sent during the survey. We have, for example, T2N0M0 squamous cell carcinoma of the tongue without any invasion of the fourth mouth. It's a patient age 55 without any comorbidities and active smoker. The tumor is 25 millimeters in length, 7 millimeters large, and 8 millimeters of depth of invasion. If we see the NCCN guidelines, the treatment of response is tumor resection plus a neck dissection or the sentinel node biopsy. For example, in Europe, almost 100% propose a tumor resection plus a neck treatment, either a neck dissection or a sentinel node biopsy. In contrast, in Asia, 32% of respondents propose a tumor resection only, without any neck treatments. Another cases about a T3N0 M0 squamous cell carcinoma of the larynx, an active smoker, age 55, without any comorbidity. In the NCCN guidelines, you can propose either an induction chemotherapy or a chemoradiotherapy or the total laryngectomy. In Europe, most of respondents propose an induction chemotherapy. In North America, Oceania, and Asia, the majority of respondents propose a chemoradiotherapy. And in Central and South America, Africa, Middle East, and North Africa, the majority of respondents propose a total or partial laryngectomy. So you can see that all these kinds of treatments proposed in the NCCN, that we have very important heterogeneity of practices between all continents. But since it seems that guidelines are not really adapted to all parts of the world, mainly because we have an evolution of recommendations with, for example, the P16 status that is used in the last TNM classification, the PDL1 that is used for immunotherapy, and the development of new technologies such as laser or robotic surgery or sentinel lymph node biopsies that are not available in all parts of the world. And in some continents, we have difficulties of access to resources, to technical and human means. The part of the responses is provided by the guidelines of the African Head and Neck Society. And I would like to thank the African Head and Neck Society and Johannes Fagan for having developed these guidelines that are adapted to limited resource settings and mainly in Africa. I don't know if it's adapted to specificities of other continents and other low-income countries, but it's a part of the response and very, very useful. So as conclusion, we have a very large database of international practice. I haven't been able to develop all results, and the study is not already published. So we are preparing the manuscripts, and when it will be published, we will have access to all data and very detailed information. And I think we have a lot of other statistical analysis to perform, for example, to compare countries with other countries in the same continents, to have information about the heterogeneity of the practices. But it's very important for us to improve our knowledge. The question is is it possible to have a standardization of head and neck cancer management across the world? Because there are many economic, cultural, and geographic specificities, and recommendation maybe should be adapted to the specificities of each regions and country. So I would like to thank you again for inviting me to this webinar, and I would like again to congratulate Sheng-Po, and I know that we are going to work together with the IFOS at least until the Congress of Istanbul in 2026, and I am very happy for that, and thank you again. Bye bye from France.
Thank you, Professor Nicolas Fakhry, for this very wonderful talk about the head and neck cancer care access from all around the world. Now we open up to the floor for discussions. Is there any questions or discussion to made?
Thank you for Nicolas' talk. It's really wonderful. May I call upon? I think there are some participants interested in this topic. May I call upon Bruce, Dr. Rosendian from Kaohsiung Changgang Memorial Hospital. Do you have any comments? Bruce? Bruce, are you online? And Bruce, are you online? Or Justin? Can everybody hear? Can everybody hear me, Justin? Or Bruce from Kaohsiung Memorial, Kaohsiung Changgang Hospital? Can you comment on this? Anyone like to comment on this? This is a very important topic. So yes, I think the IFOS, studies, IFOS survey on the head and neck cancer management is the fundamental to global head and neck surgery. It really provides some large scale basic data on our daily practice to head and neck cancer patient, and you could see there are a huge difference among different continents, and as we all know that Africa is lack of resources, and then and we could also know that the Asia and Europe almost, and South America are almost the same for the management of head and neck cancer. And however, North America still in the leading position. And surprisingly, the Oceania, which might be the Australia and New Zealand, they also have very good, head and neck cancer care. And for example, they have access to the, PET nearly 100%. So that means, in some area, the resources of, allocation, there are much difference. So anyway, I think this is very important for us to understand. And as a citizen in the world, we have some responsibilities actually to facilitate and also to help the other parts of the world. For example, we have trained so many international fellows like Justin and Beatrice now in our department. And then when they go back to their own country, they might develop their own practice, help their own people. And so that's kind of global standardization of the head and neck cancer care. And this is a very long way for everybody to go. And I encourage all of you to come with me, and actually come with my mentor, Jim Miles, to standardize, to help to raise the standard of care in head and neck cancer patient. And I think Bruce, do you have any comments? Or Justin, are you okay with your microphone now, Justin? If there isn't, then we have to close the section. And thank you again for all the participants to attend this meeting. And I sincerely hope everybody here could support Nicolas and to support the young IFOS, in which Nicolas is the current chair in the young IFOS. And then, of course, to support the head and neck program in 2026 Istanbul, IFOS. So thank you for your participation, and have a good day. Bye-bye.